Good afternoon, my dear colleagues and friends. I'm honored and delighted to be part of the second Cardiovascular Disease in Women conference, and I'd like to take this opportunity to thank Dr. Juwairiya and the organizing committee for their kind invitation. So the title of this talk is Matters Other Than the Heart, and I hope by the end of this talk I'll try to convince you that diabetes is at the heart of the problem. Right, so women, diabetes, and the heart, what do we have to say? I'd like to highlight this link that we have between diabetes and cardiovascular disease, and then explore the gender differences that are peculiar for women with diabetes in terms of their clinical outcomes. And then we'll look at some of the strategies that we can use to actually improve cardiovascular health in women with diabetes. Before I do that, these are my conflict of interest disclosures. And has already been alluded to quite elegantly throughout the conference, cardiovascular disease is the world #1 killer in both men and in women. And we know that happens as a result of abundance of modifiable risk factors that plague our communities: hypertension, diabetes, obesity, dyslipidemia, smoking, and all the rest. But as was alluded by our chair, Professor Stacey, yesterday, there are other non-traditional risk factors that are peculiar to women, involving inflammation, pregnancy outcomes, hormonal replacement therapy, stress, and so on. Now, the traditional risk factors for cardiovascular disease, hypertension, diabetes, the metabolic syndrome, are all pro-inflammatory conditions. Why am I going to concentrate on diabetes today? It is a global epidemic, and particularly for us in the Middle East and North Africa region, we are going to see a very high increase in the number of cases with diabetes in the coming years. In fact, when you look at the global diabetes prevalence by gender, again, if the pointer works, we can see that here is where we are, and in most continents as well, the prevalence rates for diabetes for women are far higher than that for men. And then we had our own local study. This was done by our colleagues in the Emirates of Sharjah, and they looked at the differences in the diabetes and pre-diabetes rates along different ethnic groups. And as you can see, if you concentrate on the orange bars, whether you're looking at UAE nationals, Asian non-Arabs, Arab non-nationals, and even Westerners and Africans, you find that the rates of diabetes are much higher in women than they are in men. So what is this connection between type 2 diabetes and cardiovascular risk? Well, there are many factors that contribute to an increased cardiovascular risk in type 2 diabetes. Starting from hyperglycemia itself, we get generation of glycated protein, which leads to advanced glycation end products that are very pro-inflammatory. There's usually concomitant hypertension, there's hyperinsulinemia, the insulin resistance results in an increase in free fatty acids, and then you have a peculiar sort of dyslipidemia that you find in people with diabetes, which all then contributes to the increased risk. So type 2 diabetes is indeed a disease of the arterial vascular system. And it confers the highest lifetime risk for coronary artery disease compared to any other single factor, compared to dyslipidemia, compared to hypertension. So here again shown women with diabetes, men with diabetes, higher rates of coronary artery disease when you compare to those without. So the absolute risk again for having a myocardial infarction is higher in people with diabetes in both genders. The other thing that we also learned from the Nurses' Health Study, and this was, of course, done in the US, is that the duration of the disease is also important. So they found that women with type 2 diabetes that was greater than 15 years, their risk for fatal coronary heart disease was very similar to those women that had a prior coronary heart disease but did not have diabetes. So here are the rates. So the duration of the disease is also important. We also know from our clinical practice and epidemiological studies that 2/3 of the deaths in diabetes are really attributable to cardiovascular disease. And it doubles the risk of all other vascular events, including cerebrovascular disease, and you will be hearing about stroke in women later on during this session. Life expectancy is also reduced by almost a decade in those individuals with diabetes and a previous cardiac event. So if you have no diabetes, you can expect to have a normal lifespan. Add diabetes and you reduce your lifespan by about 6 years, and then almost a decade in somebody who's had a coronary event. So what about the gender differences? Are there gender differences in terms of the clinical outcomes for men and women with diabetes? Yes, indeed, there are some trends and some sort of disparities as well. We know that the relative risk for fatal ischemic heart disease in women with diabetes is 50 times higher than in men. So diabetes really confers a worse vascular outcome in women compared to men. So in terms of the estimates for both ischemic heart disease and strokes, about 44% and 27% higher in men than in women. And then after you've adjusted for all those other vascular factors as well, there's nearly a 50% higher occlusive vascular mortality. The age group that we're likely to see these events is between 35 and 59 years, and then there's a 6 times higher occlusive vascular death rate among women compared to men. We also see that women have a higher risk for developing end-stage renal disease, and we know that the presence of kidney disease is an amplifier, and it increases the progression to coronary artery disease. And then this is mainly for women with type 2 diabetes, but we also see for women with type 1 diabetes, they also have a 40% higher relative risk of all-cause mortality and a 200% higher relative risk of fatal and non-fatal vascular events when you compare the two genders. And this is just to show you graphically. You can see that coronary artery disease, stroke, vascular dementia, and chronic kidney disease is almost 2 to 3 times higher in women as compared to men with diabetes. And again, here are cardiovascular events, occlusive vascular mortality, coronary heart disease, and stroke in the blue represents the women much higher than in men. So what could be some of the reasons why this is so? So the Lancet Commission, a very good paper, I recommend everybody to read this. It, highlighted some of those sex-specific risk factors: premature menopause, gestational diabetes, hypertensive disorders in pregnancy, and then you have the well-established traditional risk factors, which are common to both men and women, and then there's the more recognized risk factors, such as socioeconomic deprivation, poor health literacy, the things that we were just talking about a few minutes ago, about the challenges that we face with women post-myocardial infarction. But then I'd like to draw to your attention to the fact that there are genetic, epigenetic, and some hormonal factors that are involved in this sex difference. There is a higher expression of some of the chromosomes, decreased DNA methylation, sex chromosome instability. There's a difference in the metabolism as well that might be contributing to this excess in adverse outcomes for women with diabetes compared to men. The other thing is important to look at is the abdominal visceral fat, and it is thought that women have a stronger association of the abdominal visceral fat with insulin resistance than it occurs in men, and this may, contribute to this more adverse outcomes. There may be some sort of potential disparities in the uptake and provision of care, and we've already heard quite elegantly from Dr. Shireen about, the lack or the inadequacy of guideline-directed medical therapies in women, and the follow-up for women who've succumbed to cardiovascular events. So there's a lot of sex differences in type 2 diabetes in terms of the complications, not just the vascular complications, but also in terms of the therapies, in the way they're administered, in the way they're taken up by women, and so forth. But what's also important to recognize is that the detection and evaluation of coronary artery disease in women may be difficult because of the low sensitivity and specificity of some of the biomarkers in women. And of course, as we've already mentioned, a lot of these studies are done in men, and we're not really sure how women respond. So that's also something that we need to take in account. And again, if we look at how many physicians are informed about a woman's disease burden, this was a survey that was done some time ago, and it showed that only 8% of primary care doctors and 13% of gynecologists, only 17% of cardiologists were actually aware that heart disease as being a greater cause of death in women than in men. Then there are these misconceptions on why women don't take action against heart disease. And I think there are really misconceptions because, you know, we tend to think that women don't put their health as a top priority. They're always busy looking after other family members, but that's not really the case. Sometimes you may think that women are not old enough. You know, I may not be old enough to be having a heart attack. They may be already having a lot of other stresses in their life, but I think these are really misconceptions that need to be addressed. We've already touched upon the fact that women are vastly underrepresented in clinical trials. When we did the LEADER trial, which was one of the landmark trials for GLP-1 receptor agonists, we had 33 patients in total. Of those, only 2 were women. So yes, it is a challenge to recruit women into clinical trials. So there's a lot of initiatives actually that are currently going on to try and promote this equitable enrollment in clinical trials in order to improve cardiovascular health. The European Society of Cardiology, you know, has put forth some guidance on, you know, how we can identify and remove some of those barriers that we face in limiting women's participation, making sure that we have greater involvement in research that addresses women, supporting awareness raising activities. This is one of those. You know, it's a good forum for us to actually raise the awareness about this problem, having specific educational activities for healthcare professionals, and then increasing the number of women in the profession, you know, increasing the number of cardiologists, I think would really also help. And then Bob Harrington, which was, I think, the past president of the American Heart Association, also said we need to move beyond describing this disparity to increasing female representation in cardiovascular disease clinical trials so that the evidence for clinical decision-making matches the population with CVD. So how do we address these strategies? And I think to mitigate the problem, we need to have a proper identification of cardiovascular disease in women. That would mean that we do the trials in women. We start titrating and making sure that women as well are on guideline-directed medical therapy. We continue to engage with lifestyle modification. A lot has been said about cardiac rehabilitation and increasing access for women, and of course then increasing their representation. But I think what has been really important is probably a move towards recognizing that cardiometabolic disease needs to be managed in a holistic and in a multidisciplinary fashion. I'm glad that in Rashid Hospital, with the help of Dr. Jairia, we are going to have a cardiometabolic clinic that addresses this problem. So our patients, you know, we have a lot of a lot of patients with diabetes, men and women alike, and making sure that we're all talking, there's crosstalk between these specialties is going to help tremendously to appropriately manage detect the complications before they happen. And I mean, I would love to see that we have less people going into PCI and having CABG, right? So if I can, you know, get the cath lab closed, that would be the greatest achievement for me. So for women with diabetes, of course, and for men alike. The other thing is, of course, we have the guideline-directed medical therapies, lifestyle being so important, physical activity, the diets, use of cardiorenal metabolic agents that have been proven to have cardiorenal protection should also be accessible to everybody who deals with or looks after people with diabetes. So all I have to say is that heart disease is a now problem and later might be too much. Thank you all for your attention.